Welcome to the deep dive. Today we're setting course for a really fascinating area in surgery, the shoulder. Not just any shoulder surgery, though. We're gonna, dig into a procedure that fundamentally flips the script on how we think about shoulder replacements, reverse shoulder arthroplasty.
Hello? Yes, this procedure is, quite the game changer for patients with specific, very challenging shoulder problems where, frankly, traditional approaches just wouldn't work. It's really about rebuilding function when the body's natural design has failed in a critical way.
Exactly. And to navigate this complex terrain, we've pulled together insights from some really solid sources, the Bone School, OrthoBullets, and Stat Pearls. They give us a fantastic blend of, technical precision and clinical application.
Yes, these sources really lay out the biomechanical rationale, the specific conditions where this procedure is indicated, the intricate surgical steps involved, and crucially, what the outcomes and potential challenges are. It's a pretty complete picture of a powerful tool in orthopedics.
Our mission today, then, is to take all of that detailed material and distill it down for you. We want you to walk away understanding what makes this procedure reverse, why that reversal unlocks movement, who benefits most from it, what actually happens during the surgery, and what recovery and life afterward look like, including, the successes we see and the hurdles that can arise.
It's a procedure really born out of necessity, leveraging engineering principles to overcome quite severe biological limitations, particularly the loss of a functional rotator cuff.
Okay, let's unpack this then. Let's start with that core concept. What does it actually mean to reverse the shoulder joint?
At its most fundamental level, reverse shoulder arthroplasty, or RTSA as it's often called, maybe RSA sometimes, it's a total shoulder replacement where the normal ball and socket anatomy is completely swapped.
Right, because in a healthy shoulder, or even a standard anatomical total shoulder arthroplasty and ATSA, the setup is pretty intuitive, isn't it?
Precisely. In an anatomical shoulder, you have the glenoid, that's the socket on the shoulder blade, which is concave, and the humeral head, the top of the arm bone, which is convex, ball-shaped. An ATSA mimics this, putting a plastic socket on the glenoid and a metal ball on the humerus. It replaces worn surfaces but keeps the original design, essentially.
So the reverse procedure literally puts the ball where the socket should be and the socket where the ball should be. Is it that straightforward?
That's spot on, yes. In RTSA, a convex component, a metal sphere called a glenosphere, is fixed to the glenoid side, so onto the shoulder blade. And a concave plastic component, the humeral cup or liner, is attached to a stem placed down inside the humerus, the arm bone. So yes, the ball is on the scapula and the socket is on the arm bone.
Okay, that's a clear structural difference. But this isn't just cosmetic, it's all about function, isn't it? Why does flipping the anatomy actually work? This is where it gets really interesting, I think.
This is the genius behind the design, really, and it's all about fundamental biomechanics. The absolute key change in RTSA is the shift in the center of rotation of the shoulder joint.
Shifting the center of rotation, like relocating the joint's pivot point.
Exactly that. In the natural shoulder, the center of rotation is effectively within the humeral head itself. In RTSA, that center of rotation is deliberately moved. It's moved inferiorly, so downwards, and medialized, meaning closer towards the midline of the body.
Okay. And how does moving that pivot point enable movement, especially when you've got a damaged rotator cuff?
Well, this is the crucial insight. By shifting the center of rotation down and in, something profound happens to the deltoid muscle. The deltoid, that large muscle covering the outside of your shoulder. It now acts on a significantly longer lever arm relative to this new center of rotation.
Ah, right, like getting a longer handle on a wrench. More power with the same effort.
Precisely. That's a great analogy. This increased mechanical advantage means the deltoid muscle can now perform the functions that the damaged or irreparable rotator cuff simply can no longer do. The rotator cuff is essential for initiating and controlling abduction, lifting the arm away from the body. When it's gone, you often can't do that. The RTSA allows the deltoid, with its newfound mechanical advantage, to become the primary muscle capable of lifting the arm.
So the deltoid essentially takes over the job the rotator cuff couldn't do anymore?
It does, yes. And furthermore, the geometry of the implant, with the humeral component sitting below the glenosphere, results in a slight downward displacement of the humerus relative to the shoulder blade. This actually increases the resting tension in the deltoid muscle fibers, which further enhances its ability to function effectively.
Okay, so increased leverage and increased muscle tension.
Yes, and there's more. The design also changes how forces are transmitted across the joint. The natural shoulder, and even an anatomical replacement, relies on muscle forces for compression and stability, but it also experiences significant shear forces during certain movements. The RTSA design converts those shear forces, which can be destabilizing in a cuff-deficient shoulder, into more compressive forces, and compression inherently helps stabilize the joint.
So you gain leverage, increased muscle tension, and improved stability through force conversion. That's quite a combination.
It is. It's a multi-pronged biomechanical solution.
Yeah.
Additionally, the larger, more constrained articulation between the glenosphere and the humeral cup increases the overall contact surface area, which further contributes to joint stability. And the design also helps to, well, neutralize the deltoid's tendency to pull the humeral head upwards.
Ah, that superior escape issue.
Exactly. In a cuff-deficient shoulder, without the rotator cuff holding the head down, the deltoid can cause the humeral head to migrate superiorly and impinge against the acromion, sometimes called superior escape or the rocking horse phenomenon. The RTSA prevents this upward translation, keeping the joint centered and stable during movement.
It's really remarkable how altering the structure completely changes which muscles can function and how forces are managed. This design was truly engineered to solve a specific biomechanical failure. What's the story behind this development? When did this come about?
Well, the initial concept was actually described quite a while ago, back in the 1970s, by Beto and Alloy, though their outcomes weren't widely reported at the time. The real pioneer who brought this concept to clinical fruition was Paul Grammont in France. He reported his first cases in 1987 with what was called the Trompette prototype.
Trompette, a very distinctive name.
It was, yes. Grammont's key contribution was the concept of medialization, shifting that center of rotation closer to the body, which we just discussed. This idea emerged from his work in the early 1980s. A second generation of the Grammont prosthesis was developed in 1991, featuring a larger glenoid hemisphere, and quite specifically, a 155-degree neck shaft angle on the humeral component.
And when did it become available more widely? I assume it took time to cross the pond.
It did. It gained popularity in Europe first, before being introduced in the USA in 1998. Since then, designs have continued to evolve, naturally. Newer systems often feature smaller neck shaft angles, perhaps 135 or 145 degrees.
Was changing that angle a response to issues with the earlier 155-degree design?
Precisely. While the 155-degree angle was very effective for achieving the medialization and the lever arm effect, it became strongly associated with a specific complication: scapular notching. That's wear on the bone of the shoulder blade, just below the implant. Newer designs aim to reduce this notching and potential impingement while retaining the essential biomechanical benefits by adjusting the angles and incorporating other design features like lateralization or eccentricity of the components.
Okay, so what does this whole evolution and these mechanics tell us, fundamentally?
It tells us that RTSA is a sophisticated, tailored solution. It's not a standard replacement. It's a procedure specifically designed to restore the ability to lift the arm by dramatically altering the joint's mechanics. It enables the deltoid muscle to substitute for a non-functional rotator cuff. This addresses a problem that traditional anatomical replacements simply cannot fix effectively.
Fascinating. It's really about working with the remaining muscle power by changing the leverage. Given its unique mechanics, then, this procedure can't be used for every shoulder problem, right? What are the specific conditions or indications where reverse shoulder arthroplasty is actually the appropriate choice?
That's a critical point, absolutely. RTSA is indicated for specific clinical scenarios where the conventional ball and socket mechanics have failed or are predicted to fail. The primary, most common indication is something called rotator cuff tear arthropathy.
And you mentioned before that this isn't just a simple tear, is it? It's the combination of problems.
Exactly. Rotator cuff tear arthropathy is a severe type of glenohumeral arthritis, so wear and tear in the joint, that develops specifically because of a massive, irreparable tear of the rotator cuff. Without the cuff to dynamically center the humeral head on the glenoid during movement, the head drifts upwards superiorly. This superior migration leads to abnormal contact and wear between the humeral head and the acromion bone above it, causing significant joint destruction and pain, alongside a loss of function from the torn cuff itself.
And this often leads to something called pseudoparalysis. What exactly is that?
It does, yes. Pseudoparalysis is a key clinical sign of severe rotator cuff deficiency, often seen in cuff tear arthropathy. It's the inability to actively lift or elevate the arm, despite having normal or perhaps near normal passive range of motion when someone else moves your arm for you. It's not due to a nerve problem, that's the key thing. It's because the mechanical link needed for the deltoid to elevate the arm is essentially broken by the lack of a functional rotator cuff and that superior migration of the humeral head. Sometimes this is termed an incompetent coracomial arch. You might even see the humeral head sitting visibly higher under the skin in severe cases.
So RTSA is specifically designed for this scenario where the rotator cuff is beyond repair and the joint is arthritic and unstable, often with that inability to lift the arm. What other situations call for this reverse approach?
Well, another significant indication, particularly in older adults, is complex fractures of the proximal humerus. That's the top part of the arm bone near the shoulder joint. We're talking about acute 3- or 4-part fractures, especially in patients typically over 70 years old, or perhaps those with complex head-splitting fracture patterns. In these cases, the bone quality is often poor, and the fragments where the rotator cuff attaches, the tuberosities, are severely damaged, making it very difficult or sometimes impossible to successfully repair the bone and restore rotator cuff function. And RTSA can provide a more reliable way to restore some functional elevation compared to trying to fix shattered bone or performing a hemiarthroplasty where the cuff will likely fail anyway.
That makes sense. If the foundation you'd normally attach the cuff tendons to is destroyed, you need a different kind of anchor point and mechanism.
Well, exactly. RTSA is also often a go-to procedure for revision shoulder arthroplasty. That's when a previous shoulder replacement, either an anatomical TSA or a hemiarthroplasty, has failed. Failure can happen for various reasons, but often it's due to subsequent rotator cuff failure after an ATSA, or maybe ongoing pain and poor function after a hemiarthroplasty, especially if the cuff wasn't functional to begin with or subsequently failed.
So it's the salvage option when the first replacement didn't work out, particularly if the cuff is now involved.
Correct. Other indications mentioned include post-traumatic glenohumeral arthritis, so arthritis developing years after a significant shoulder injury, and also chronic irreducible shoulder dislocations where the shoulder has been dislocated for a long time and simply cannot be put back into place non-surgically.
And what about inflammatory conditions like rheumatoid arthritis? Can RTSA help there?
It can be an option in inflammatory arthritis like RA, yes, but there's a very important caveat mentioned in the sources. The patient must have sufficient glenoid bone stock. Rheumatoid arthritis can cause significant bone erosion, and you absolutely need a solid base of bone on the shoulder blade to securely fix the RTSA glenoid component. Without good bone, it's likely to fail.
That brings us back to the importance of bone quality, which was also key in the fracture scenario, wasn't it?
Indeed. We also sometimes see RTSA used for conditions considered sort of rotator cuff insufficiency equivalents. This could be something like a non-union or malunion of the greater tuberosity after a fracture, where the bones the rotator cuff attaches to haven't healed properly. This effectively renders the cuff non-functional, despite the muscle itself potentially being intact.
You mentioned a slight question mark indication earlier in the outline, something debated.
Yes, some sources discuss RTSA as an option, although it remains, well, debated and requires careful comparison to ATSA for patients over 70 who have glenohumeral osteoarthritis but actually have an intact rotator cuff. While ATSA is the traditional choice here, some surgeons consider RTSA, particularly if there are concerns about significant glenoid wear or perhaps other factors. Research, like the systematic reviews we'll discuss later, is helping to clarify the trade-offs and outcomes and complication profiles between the two procedures in this specific older intact cuff population.
Okay, so it sounds like the ideal RTSA candidate generally is an older patient with significant pain and loss of function, often due to a non-functional rotator cuff, but importantly, with enough bone quality and a working deltoid muscle.
That's a very good summary of the typical patient profile. Key characteristics often include lower functional demand. They're usually not looking to return to high-level sports, for example, a physiological age, often over 70, adequate bone density on the glenoid side, and crucially, as you say, an intact functional deltoid muscle and a working axillary nerve to power it. Without a functioning deltoid, the core mechanism of RTSA simply doesn't work.
That makes perfect sense. The deltoid is the engine, really. Which brings us neatly to the flip side. When should reverse shoulder arthroplasty absolutely not be done? What are the contraindications?
Right, the contraindications are situations where the procedure either won't work biomechanically or carries an unacceptably high risk of failure or harm. The most absolute contraindication is significant axillary nerve dysfunction resulting in a non-functional deltoid muscle. If that nerve is permanently damaged, the deltoid won't fire, and the RPSA relies on it completely. It's very important during assessment to distinguish between temporary nerve stunning, maybe from an injury, and permanent damage.
Right, you need to be sure the nerve isn't just temporarily bruised or stretched.
Exactly. And relatedly, global deltoid deficiency is a contraindication. If the entire deltoid muscle is absent or severely atrophied, perhaps from previous surgery or injury, there's no muscle to drive the reverse mechanics. Partial deltoid deficiency might be considered a relative contraindication, meaning it's not an absolute no, but the functional outcome might be compromised, and the patient needs to understand that.
Are there structural issues, bone problems that make it impossible?
Yes, significant acromion deficiency is a contraindication. The acromion provides important bony coverage and stability, and if it's severely deficient, the biomechanics and stability of the reverse construct are compromised. Severe deficiency in glenoid bone stock, or very poor bone quality due to conditions like severe osteoporosis, can also contraindicate the surgery, as you need that stable base for the glenoid component that won't loosen over time.
Okay, and infection.
Active infection anywhere in or near the shoulder joint is an absolute contraindication. You can never put a large foreign body, like an implant, into an infected field. The infection must be completely eradicated first, often requiring a staged surgical approach with antibiotics.
And what about age on the younger side?
Skeletal immaturity is a contraindication because the bones are still growing and developing. Finally, any severe neuromuscular disorder that would significantly increase the risk of the prosthesis dislocating or severely impair the patient's ability to participate in rehabilitation would also generally contraindicate the procedure, as maintaining stability and achieving function postoperatively is paramount.
This clearly shows that patient selection is incredibly important. It's not a procedure for everyone. Given these specific requirements, the need for a functioning deltoid, good bone, how do surgeons actually make this decision, and what rigorous preparation is needed before a patient heads into the operating theater?
Patient selection and meticulous preoperative planning are absolutely crucial for a successful RTSA. It's definitely not a surgery to be taken lightly, and the work begins long before the patient arrives in the operating room.
So it starts with that detailed history and clinical exam we touched on, really understanding the patient.
Precisely.
Yeah.
A comprehensive patient history is vital, understanding their overall health, any medical conditions, comorbidities like diabetes, heart disease, obesity, smoking status, medications they're taking, and importantly, their functional goals and expectations for the surgery. Optimizing these medical conditions before surgery is necessary to minimize risks. The physical examination is equally thorough, assessing both active and passive range of motion, specifically testing the strength and function of the deltoid and any remaining rotator cuff muscles, and confirming axillary nerve integrity. You also carefully check the skin condition around the shoulder and the neurovascular status of the entire limb. Sometimes an examination under anesthesia is performed just before the surgery starts to get a truly relaxed assessment of passive motion and soft tissue tension.
Imaging must be absolutely key then, to understand the underlying bone and soft tissue issues in detail.
It is fundamental, yes. Standard shoulder x-rays are the foundation. True AP or Grashy views, axillary laterals, and scapular Y views. These are used for initial assessment, seeing the degree of arthritis, confirming that telltale superior migration of the humerus and cuff tear arthropathy, assessing for posterior glenoid wear, identifying any bony lesions, and getting a general sense of bone quality. They're also used for initial templating, which is estimating the likely implant size needed.
And what additional detail does a CT scan provide that X-rays don't?
A CT scan is very often necessary, particularly if standard X-rays don't provide enough clarity, or if there are complex bone defects or fractures suspected. CT gives a much more detailed three-dimensional picture of the bony stock on both the humerus and, critically, the glenoid. It's essential for accurately measuring glenoid version, that's the tilt or angle of the socket relative to the scapula blade, and assessing the degree of osteopenia or bone loss. Preoperative 3D CT reconstructions are becoming increasingly valuable, almost standard of care in complex cases, because they allow for precise 3D planning. This helps determine the optimal proximal humeral retroversion for implant placement and, critically, allows for a detailed 3D assessment of any glenoid bone defects. This guides accurate baseplate positioning and sometimes even facilitates the design of patient-specific instruments or bone grafts.
So 3D imaging allows for almost a virtual rehearsal, letting the surgeon plan how to tackle tricky bone situations beforehand.
Exactly. It allows the surgeon to anticipate challenges, plan the correction of deformities, and tailor the implant placement specifically to the patient's unique bone structure. This is crucial for achieving long-term stability and reducing complications like component loosening or scapular notching. An MRI scan might also be part of the planning process. It's primarily used to assess the status of the remaining rotator cuff tendons and look for fatty infiltration within the muscles before surgery. This helps confirm the diagnosis of an irreparable cuff tear or assess the quality of any residual muscle tissue that might contribute to function or need to be protected during the surgery.
So you combine the clinical picture, the detailed imaging, ensure the patient is medically fit, check relevant blood tests perhaps to rule out underlying infection, and manage any medications like blood thinners. It sounds like a lot of pieces have to align perfectly before the surgery itself can proceed.
It is a significant amount of preparation, yes. This meticulous preoperative phase is fundamental to choosing the right patient, selecting the appropriate implant components and sizes, anticipating potential intraoperative challenges like managing bone defects, and ultimately maximizing the likelihood of a successful outcome with restored function and minimal complications. With that comprehensive planning complete, the next stage is, of course, the procedure itself.
Right, let's walk through the surgery then. What position is the patient in, and how is the anesthesia typically managed for this?
Okay, so patients undergoing RTSA are typically placed in what's called the beach chair position. This is where the patient is essentially semi-sitting with their chest tilted up, often to about 60 degrees. The operative shoulder needs to be positioned right at the edge of the operating table. This allows the surgeon maximum flexibility and access, particularly enabling the arm to be extended backwards during specific parts of the procedure for optimal exposure of the joint.
And anesthesia.
Anesthesia usually involves general anesthesia, often supplemented with a regional nerve block, such as an interscalene brachial plexus block. This provides excellent pain control both during and immediately after the surgery. Prophylactic intravenous antibiotics are given just before the skin incision to reduce the risk of surgical site infection, and sometimes tranexamic acid is administered intravenously to help minimize blood loss during the operation.
And before the actual incision, is there a final check or assessment?
Yes, frequently an examination under anesthesia is performed, as I mentioned briefly before. This allows the surgeon to accurately assess the true passive range of motion and the tension in the surrounding soft tissues without the patient experiencing any pain or involuntary muscle guarding. This information can be valuable in confirming the preoperative plan and informing decisions about the extent of capsular release needed during the procedure to achieve good motion.
Okay. Now, for actually accessing the joint, the sources mention two main surgical approaches. What are they, and how does the surgeon typically choose between them?
That's right. The two primary approaches described are the deltopectoral approach and the anterosuperior approach. The choice often depends on several factors, including the specific pathology being treated, like fracture versus arthritis, whether the patient has had previous surgery, the surgeon's own experience and preference, and sometimes specific patient factors.
Let's start with the deltopectoral approach, which the sources described as the most common one used.
Yes, the deltopectoral approach utilizes an incision that follows the natural groove between the deltoid muscle laterally and the pectoralis major muscle medially on the front of the shoulder. It's developed through what's called an internervous plane, which means you're essentially working between the territory supplied by the axillary nerve to the deltoid and the pectoral nerves to the pec major, aiming to minimize muscle damage. You carefully identify and protect the cephalic vein, usually moving it laterally out of the way. You then identify and gently retract the conjoint tendon, that's the common tendon of the short head of the biceps, and the coracobrachialis muscle medially, being very careful to protect the musculocutaneous nerve, which runs near or through it. The clavipectoral fascia overlying this is incised, and then the subscapularis muscle, the most anterior rotator cuff muscle, is accessed. To expose the joint fully, the subscapularis muscle is typically released or taken down, usually laterally near its insertion on the humerus. The joint capsule underneath is then incised and released circumferentially to gain full access to the glenohumeral joint.
That sounds like quite a careful dissection through several layers. What are the main advantages of using this approach for RTSA?
The deltopectoral approach has several key advantages. Crucially for RTSA, it preserves the origin of the deltoid muscle from the clavicle and acromion, which is vital for ensuring good deltoid function post-surgery, and the deltoid is doing all the work, remember. It provides excellent exposure of the inferior part of the glenoid, which is absolutely essential for accurate inferior placement of the glenoid base plate, a key factor in reducing complications like scapular notching. The incision can also be easily extended downwards if more exposure of the humerus is needed, for example in revision cases or complex fractures. It also allows for potential simultaneous procedures like a latissimus dorsi transfer if that's indicated. And generally, the risk of direct injury to the main trunk of the axillary nerve is considered lower with this approach compared to the anterosuperior one.
And the trade-offs, what are the disadvantages?
The main disadvantage is that you have to release the subscapularis muscle.
Oh.
While this muscle is often torn or non-functional in rotator cuff tear arthropathy anyway, taking it down and potentially repairing it at the end requires protection during the early healing phase, typically involving a period of immobilization and restricted movement. This carries a risk of the repair re-tearing and potentially leading to anterior instability if it fails. It can also offer slightly less direct exposure to the very posterior aspect of the glenoid compared to other approaches, and the required immobilization period might contribute to some postoperative stiffness in certain patients.
Okay, so there's that balance between preserving the deltoid origin versus needing to manage the subscapularis tendon. What about the alternative, the anterosuperior approach? How does that differ?
The anterosuperior approach uses a different incision pattern, typically starting near the AC joint and extending laterally over the top in front of the shoulder. In this approach, some of the anterior fibers of the deltoid muscle are actually detached from their origin on the acromion, where the muscle is split in line with its fibers. You then access the joint by incising through this deltoid split or detachment and the underlying rotator interval tissues, exploring the subacromial space and any remaining cuff tendons.
Detaching deltoid fibers sounds potentially significant. What are the advantages that make surgeons choose this route sometimes?
The anterosuperior approach can offer potentially better exposure of the glenoid, particularly the superior portion. A key perceived advantage is that it allows for preservation of the subscapularis muscle, as you don't typically need to release it. This can lead to a decreased risk of anterior instability postoperatively. It can also simplify the preparation of the humeral canal in some situations and may make it easier to manage and fix tuberosity fragments directly, which can be beneficial in certain fracture cases.
And the disadvantages associated with detaching or splitting the deltoid.
The main concern here is an increased potential risk of injury to the distal branches of the axillary nerve that supply the anterior deltoid, as you are working directly through or near the muscle belly itself. It inherently involves violating the anterior deltoid muscle origin or substance, which some surgeons prefer to avoid if possible, given the reliance on the deltoid post-RTSA. There's also potential risk, though generally manageable with careful technique, of positioning the glenoid component slightly too high or with a superior tilt, which is something you definitely want to avoid as it increases notching risk.
So the surgeon carefully weighs these factors prior surgery, the specific bone defects, the need for exposure in certain areas, the relative risks to nerves and tendons to choose the most appropriate approach for that individual patient. Once the joint is successfully opened, what's the next major step in preparing the bones?
Regardless of the approach used to get there, the next major step is preparing the humerus, the arm bone. This begins by dislocating the humeral head from the glenoid socket. This is achieved by carefully manipulating the arm, often adducting it across the chest, externally rotating it, and applying gentle upward and forward force to lever the head out of the socket. Once dislocated, you then remove any significant bone spurs or osteophytes from around the proximal humerus. This helps to clearly identify the anatomical landmarks and the correct level for the humeral head resection.
Where is the humerus typically cut for an RTSA? Is it the same as for an anatomical replacement?
It's often slightly different. The humeral head is resected using a surgical saw and specific cutting guides. The cut is typically positioned slightly below the tip of the greater tuberosity. The angle of the cut relative to the long axis of the humerus, specifically its rotation or retroversion, is crucial. The sources mention cutting the humerus in anywhere from 0 to 30 degrees of retroversion relative to the axis of the forearm when the elbow is bent. A retroversion of at least 20 degrees seems to be increasingly favored, as studies suggest it may help improve postoperative external rotation, which can be limited after RTSA.
Okay, so the head is resected. Then what happens to the humerus?
The intramedullary canal, the hollow center of the humerus, is then prepared using a series of instruments called reamers and broaches. These gradually shape and size the canal to accept the humeral stem component of the prosthesis. A version rod is often attached to the final broach instrument to help the surgeon ensure the correct amount of retroversion is maintained during this preparation stage.
And how do they determine the correct height for the humeral component? That must be important for getting the tension right later on.
Yes, determining the correct humeral height is very important for achieving proper soft tissue tension and stability. In non-fracture cases, the surgeon can often reference remaining anatomical landmarks, like the calcar bone medially or the tuberosity fragments laterally. However, in complex fracture cases, these landmarks are often missing or unreliable. In those situations, a reliable reference point is the insertion site of the pectoralis major tendon on the humerus. Studies have shown this insertion is consistently located around 5.6 centimeters below the normal top of the humeral head, providing a useful guide for positioning the humeral component at the correct height.
That's a very specific anatomical measurement guiding the surgery. What about the different types of humeral stems used, cemented or uncemented?
There are generally two types. Press-fit cementless stems, which are designed to have a tight fit within the bone and rely on the patient's bone growing into the implant surface for long-term stability, and cemented stems, which are fixed into place using bone cement. For press-fit stems, the final size of the stem used is typically determined by the size of the last broach instrument used during preparation. For cemented stems, a slightly smaller stem is usually chosen to allow for an even mantle of bone cement all around it. If cement is used, antibiotic-loaded cement is often favored to help reduce the risk of infection, and a cement restrictor, like a small plastic plug, is placed further down the canal first to prevent the cement from going too far down the bone.
Right. Once the humerus is prepared, the focus shifts across to the glenoid side, the socket.
Yes, exactly. The glenoid is now fully exposed. If the subscapularis was released during the approach, it's retracted medially out of the way. Any remaining labrum tissue around the glenoid rim is removed, and the joint capsule is released circumferentially to ensure maximum visualization and access, particularly to the inferior aspect of the glenoid. It's vital to clearly identify the bony anterior margin of the glenoid, typically around the 5 o'clock position on the right shoulder or the 7 o'clock position on the left shoulder, looking at it face on. The surgeon then carefully inspects the glenoid surface and its bony margins for any wear patterns or bone defects, which are actually quite common, especially posterior wear or superior wear in cases of cuff tear arthropathy.
And how are those bone defects managed? You can't just put the implant on uneven bone, presumably.
No, managing glenoid bone defects is absolutely crucial for achieving secure baseplate fixation and preventing long-term complications like loosening. Smaller defects, perhaps representing less than 25 degrees of version deformity or wear, can often be managed by techniques like eccentric reaming, which means reaming more bone from the high side than the low side to create a flat surface, or sometimes by adding bone graft to the deficient area. For example, with typical superior wear, you might ream more inferiorly or add a small bone graft superiorly to build it up. However, for larger defects, often exceeding 25 degrees of version abnormality or significant bone loss, patient-specific structural bone grafts, often planned meticulously using those preoperative 3D CT scans, are frequently required to reconstruct the glenoid shape before the base plate can be placed securely.
And getting the base plate positioned correctly sounds critical.
It is absolutely critical for the long-term survival of the implant and minimizing complications like loosening or notching. A crucial step here is performing a superior steel elevation just below the inferior glenoid rim. This elevates the soft tissues to ensure the glenoid base plate can be seated flush against the bone surface as far inferiorly as possible.
So aiming low on the glenoid face.
Yes, the goal is to position the base plate as inferiorly on the glenoid face as possible, often with a slight intentional inferior tilt. Studies have suggested that around 10 degrees of inferior tilt might help reduce the risk of the base plate loosening over time by converting shear forces into compression, although its effect on preventing notching is more debated. A central pilot hole is drilled, usually guided by a wire, to center the glenoid reamer. The glenoid surface is then reamed to create a flat, bleeding surface of subchondral bone, preparing it perfectly for the base plate. The base plate itself is then applied, ensuring it's flush with the bone and initially compressed onto the surface using a central screw. Then multiple peripheral screws are inserted, typically aiming superiorly towards the strong bone at the base of the coracoid process and inferiorly towards the dense bone of the lateral scapular body to achieve strong, stable, multidirectional fixation. Advancements like variable angle locking screws and central compressive locking screws have been introduced in newer systems to further improve this initial stability and resist micromotion at the interface, which is thought to be a precursor to loosening.
So the base plate is locked solidly onto the shoulder blade. What comes next on the glenoid side, the ball part?
That's right, the glenosphere. Once the base plate is securely fixed, the glenosphere trial component is placed onto it. Glenospheres come in various sizes, typically ranging from about 32 up to 42 millimeters in diameter, with common sizes being perhaps 36 millimeters for many female patients and 40 millimeters for males, although it depends on the individual patient's anatomy. Modern designs also offer variations in lateralization, how far the sphere sits out from the baseplate, or eccentricity, where the center of the sphere is offset from the center of the baseplate. These newer geometries are specifically designed to try and reduce that scapular notching problem and potentially improve the range of motion by moving the area of potential impingement further away from the bone.
And you're trialing different sizes and offsets at this stage to get the best fit.
Exactly. The surgeon will trial different glenosphere diameters, offsets, lateralization, and potentially eccentricities to find the combination that achieves optimal soft tissue tension around the joint and allows for the best possible range of motion without the components impinging on each other or on the surrounding bone. They visually check for clearance between the glenosphere and the scapular pillar anteriorly, posteriorly, and especially inferiorly, and ensure the planned humeral component won't hit the acromion bone above during arm elevation.
Once the glenosphere trial is satisfactory, you then go back to the humerus side to trial those components.
Yes, precisely. You then trial the humeral components. The humeral tray, which attaches to the top of the stem already prepared in the humerus, and the polyethylene insert, the plastic socket part which will articulate with the metal glenosphere, are placed onto the humeral stem trial. The entire trial prosthesis is then carefully reduced, meaning the humeral component is seated onto the glenosphere, bringing the arm and shoulder blade components together into the final joint configuration. The surgeon then meticulously tests the range of motion in all directions, checks for stability throughout the arc of movement, and assesses the soft tissue tension. They'll manually feel the tension of the deltoid, the conjoint tendon, and sometimes the triceps to ensure it's not too loose, which would risk dislocation, or excessively tight, which could risk stiffness, pain, or even nerve traction.
So you're really fine-tuning the implant fit and the resulting muscle tension at this stage. It sounds like a delicate balancing act.
It is, exactly. You might try different heights of the polyethylene insert if necessary to adjust the tension. If the soft tissue tension feels too high even with the thinnest insert, or if the prosthesis is very difficult to reduce, the surgeon may make the decision to resect the proximal humerus at a slightly lower level to effectively shorten the humerus slightly, reducing tension and creating a bit more space.
Once everything feels optimal with the trial components, then the definitive final components are implanted.
That's right. The trial components are all removed. The definitive glenosphere is implanted onto the base plate first. This is generally easier to do while there's still more space before the humeral component is fully in place. Then the definitive humeral stem is implanted, either cemented or press-fit depending on the plan. The definitive metal humeral tray is attached securely to the top of the stem, followed by the final polyethylene insert which snaps into the tray. The definitive prosthesis is then reduced one last time, and a final check for stability, range of motion, and appropriate soft tissue tension is performed. Before closing, the surgical site is thoroughly washed out with saline solution.
And that final step we touched on earlier, what about repairing the subscapularis muscle if it was released?
That's often the final decision made just before starting the closure. As the sources mention, whether or not to repair the subscapularis after taking it down during the deltopectoral approach is still somewhat debated among surgeons. There is some evidence suggesting that repairing it might lead to improved internal rotation strength or function postoperatively, but studies haven't consistently shown a significant difference in postoperative instability rates compared to not repairing it, especially if the tissue quality is poor. The decision often rests on the surgeon's preference and their intraoperative assessment of the quality of the remaining subscapularis tissue. If it's very thin, degenerated, or retracted, a repair might not be feasible or likely to hold anyway.
Wow. That level of detail in the procedure really highlights how much goes into tailoring this surgery to each patient's specific anatomy, bone quality, and pathology. It's clearly not a one-size-fits-all operation.
No, it is a highly technical and complex procedure requiring significant surgical expertise and judgment at multiple steps along the way to ensure correct implant positioning, appropriate component sizing, stable fixation, and optimal soft tissue balance for the best possible outcome.
Okay. Once the surgery is successfully completed, the patient moves into that crucial phase of recovery and rehabilitation. What does life after a reverse shoulder arthroplasty typically look like in terms of postoperative care and the rehab process?
Postoperative care and rehabilitation are absolutely essential for maximizing the functional outcome after RTSA. It really is just as important as the surgery itself. It's a phased process, carefully guided to protect the healing tissues while gradually restoring movement and strength over several months.
Let's talk about the immediate post-surgical phase first, say the first few weeks. What happens then?
In the immediate phase, typically the first 4 to 6 weeks, the operated arm is immobilized in a sling to protect the shoulder. A specific type of sling, sometimes called a board arm sling or abduction pillow sling, might be used for about the first 2 weeks for added protection and comfort. A critical restriction during this early time is avoiding active external rotation, and usually passive external rotation beyond neutral, 0 degrees, for at least the first 4 weeks. This is particularly important if the subscapularis muscle was repaired during surgery to allow that repair time to start healing without tension.
What kind of movement is allowed early on then? You can't just keep it completely still, can you?
Yeah. No, early controlled movement is important to prevent stiffness elsewhere. Pendulum exercises, gentle swinging motions of the arm initiated by body movement, are usually started very soon after surgery. Along with that, gentle active and passive movements of the elbow, wrist, and hand on the operated side are encouraged to maintain their function. The sling itself is generally discontinued around 3 weeks if the subscapularis was not repaired, but often worn for a longer period, sometimes up to 6 weeks, if it was repaired, based on surgeon preference and the repair quality. Patients are also given specific instructions on activities to avoid, such as avoiding using the operated arm to push themselves up out of a chair, which puts significant stress on the implant and any repairs.
So the initial focus is very much on protection and very gentle, controlled motion.
Exactly. The main goals in this early phase are joint protection, managing pain and swelling effectively, often using ice packs or cryotherapy devices, achieving passive or active assisted range of motion within prescribed safe limits, and helping the patient regain basic independence with personal care tasks while wearing the sling. The first formal physical therapy visit usually takes place around 8 to 10 days post-op once the initial wound healing is underway, to begin the structured rehabilitation program under guidance.
What about the risk of that subscapularis repair tearing, if one was done? Is that a concern in this early phase?
Yes, if the subscapularis was repaired, a re-tear is a potential complication in this early phase, particularly if the restrictions aren't followed. A significant re-tear could potentially lead to anterior instability of the prosthesis. This would typically manifest as pain, a feeling of instability, or difficulty with certain movements, and would require early recognition and potentially further intervention, possibly surgical exploration and re-repair if feasible.
Okay. Moving into the mid-recovery phase then, say from around 6 weeks to 3 months post-op, what changes?
By the mid-recovery phase, patients are typically attending outpatient physical therapy sessions, perhaps 2 or 3 times a week. The focus starts to shift gradually from mainly passive protection towards more active movement and the initiation of gentle strengthening exercises. Patients are usually cleared to begin using their arm for light, below-shoulder height everyday activities, but still with significant restrictions on lifting weight, usually nothing heavier than a cup of tea initially. The goals during this phase include managing any residual pain and swelling, progressing stretching exercises to improve range of motion further within limits, and beginning very light strengthening exercises, such as controlled isometric contractions and gentle active exercises like shoulder flexion and scapular retraction exercises.
Sounds like a gradual but definite increase in activity and strengthening, and then into the late recovery phase, perhaps from 3 to 6 months.
Yes, this period, from 3 to 6 months, is typically when most patients experience really significant functional gains. Physical therapy becomes more intensive, focusing on building greater muscle strength, endurance, and coordination required for more complex movements and functional activities. However, even during this phase, patients are generally advised to continue avoiding heavy lifting, repetitive overhead activities, and certainly any high-impact sports or activities that could put excessive stress on the implant. Adhering closely to the physical therapy program and the surgeon's specific guidelines remains essential to consolidate the recovery and protect the long-term outcome.
And what's the typical timeline for feeling like you've reached, well, full recovery or as good as it's going to get?
Full recovery can vary quite a bit between individuals, but most patients see substantial improvement and are able to perform most of their desired daily tasks with much less pain and significantly improved function by around the 6-month mark. However, continued improvements in strength, endurance, and even range of motion can often occur for up to a year, or sometimes even longer, after the surgery as the muscles adapt and conditioning improves. Regular follow-up appointments with the surgical team throughout this period, perhaps at 6 weeks, 3 months, 6 months, and a year, are important to monitor progress, check on the implant stability radiographically, and address any issues or concerns that may arise.
It's certainly clear from that description that the rehabilitation after the surgery is just as important, if not more so in some ways, than the surgery itself for achieving a good result.
Absolutely. The surgery provides the necessary mechanical alteration, the foundation for potential improvement. But dedicated, appropriate, and often prolonged rehabilitation, guided by experienced therapists, is crucial to translate that surgical potential into meaningful, lasting functional recovery for the patient. It requires significant patient commitment.
Now, the crucial part for many patients considering this. Let's talk about the results. What can patients realistically expect in terms of outcomes, both good and bad? And what are the potential problems or complications they really should be aware of?
Yes, this is a critical conversation for informed consent and setting realistic expectations. Let's start with the positive outcomes, what we generally hope to achieve.
What do the studies and perhaps the big joint registries tell us about pain relief and overall patient satisfaction after RTSA?
The data is generally very positive regarding pain relief, which is often the primary goal for many patients. Studies like the 2023 systematic review by Doyle and colleagues, which looked at over 1,600 RTSAs with at least 5 years of follow-up, reported that around 88% of patients had good or excellent patient-reported outcomes overall. This aligns well with other findings suggesting that roughly 85–90% of patients experience excellent relief from the often severe, debilitating pain associated with conditions like end-stage rotator cuff tear, arthropathy. For patients whose lives are dominated by shoulder pain, this level of relief can be truly life-changing.
That's a very high success rate for pain relief. And what about restoring the ability to lift the arm? What kind of range of motion gains are typically seen? We know it relies on the deltoid.
Yes, there are usually significant gains in active motion, particularly in elevation. The 2022 systematic review by Galvin and colleagues found mean improvements of about 56 degrees in active forward flexion, lifting the arm forwards, and 50 degrees in active abduction, lifting the arm out to the side. The Doyle review reported specific mean ranges of motion achieved at a minimum 5-year follow-up. Active forward flexion averaged 126 degrees, active abduction averaged 106 degrees, active internal rotation, like reaching behind the back, was more limited, averaging about 6 degrees of improvement, often reaching the lumbar spine. So, while it doesn't typically restore completely normal, full range of motion, these improvements allow most patients to use their arm much more effectively for activities of daily living, particularly lifting the arm above shoulder height, which they often couldn't do at all before surgery.
Do these outcomes vary much based on the original problem the patient had, why they needed the RTSA in the first place?
Yes, they do seem to. The 2022 systematic review by Paris and colleagues specifically compared outcomes when RTSA was done for rotator cuff arthropathy versus complex proximal humerus fractures. They found that patients treated for fractures generally had somewhat worse functional outcome scores and achieved less range of motion compared to those treated for rotator cuff arthropathy. This suggests that the underlying pathology, the amount of initial trauma, and perhaps the complexity of the surgical reconstruction required can influence the functional ceiling that's ultimately achievable.
And let's revisit that question mark indication we discussed earlier. Older patients, say over 70, with osteoarthritis but an intact rotator cuff. How does RTSA stack up against the traditional anatomical TSA in that specific group? The evidence seemed a bit mixed.
It is an area of active research and ongoing debate, and the studies show some interesting, perhaps complex trade-offs. A large 2023 systematic review by Dragonis and colleagues, comparing over 1,400 anatomical TSAs and over 1,200 RTSAs in patients over 70 with intact cuffs, found that ATSA resulted in better overall functional outcome scores. However, quite notably, they also found an increased revision rate associated with ATSA in this specific older population compared to RTSA.
So potentially better functional scores, maybe better rotation with the anatomical approach, but a higher chance of needing another surgery later down the line compared to the reverse in this older group. That's a really complex decision point for both surgeon and patient.
It certainly is. Another meta-analysis by Kim and colleagues in 2022 looked at 6 studies comparing ATSA and RTSA in patients with intact cuffs. They found no significant difference in overall functional scores between the two procedures. They did note, however, that ATSA generally led to better external rotation, while ATSA was associated with increased rates of glenoid component loosening over time. Conversely, RTSA was associated with increased rates of scapular notching. So neither procedure appears clearly superior across all metrics for this specific group, and the potential long-term risks seem to differ. It really requires careful patient counseling.
What about differences between the implant designs themselves? The sources mention inlay versus onlay humeral components. Does that make a difference to outcomes?
Studies comparing inlay and onlay humeral component designs show somewhat varied results when it comes to functional scores. Some systematic reviews, like those by LaRose et al. And Meshram et al., suggested slightly higher functional scores, like the AC score, with inlay designs. However, other studies, like one by Giordano, found no significant difference in ACs or constant Murley scores. Jackson's systematic review reported slightly better average forward flexion with onlay designs, around 142 degrees, compared to inlay designs around 136 degrees, although this difference wasn't statistically significant.
So perhaps not huge functional differences reported consistently, but maybe differences in the types of complications seen with each design.
That appears to be the emerging picture, yes. Inlay designs have been more strongly associated with an increased risk or severity of scapular notching. Onlay designs, on the other hand, seem to be linked to a potentially increased risk of scapular spine fractures. These are important considerations for the surgeon when choosing a specific implant system, balancing the potential benefits and risks of each design philosophy.
Okay, let's shift focus now and talk more directly about those potential complications. The sources provide some quite robust data, particularly referencing large joint registries like the Australian one. What does that registry data tell us about how often revisions needing a second operation are actually required after RTSA?
The Australian Joint Registry provides invaluable real-world long-term data on large numbers of patients, which is incredibly useful. Their 2024 report shows the overall 14-year revision rates for RTSA broken down by the original indication for the surgery. For rotator cuff arthropathy, which is the most common indication over 20,000 cases, the 14-year revision rate was 6.1%. For osteoarthritis, which includes some of those intact cuff cases over 24,000 cases, the rate was slightly higher at 6.7%. And for fracture cases, around 8,000, the 14-year rate was 5.9%. So these long-term revision rates are actually relatively similar across the main indications, hovering around 6-7%.
That's lower than I might have guessed for 14 years. Are there demographic factors that influence these revision rates significantly? Age or gender?
Yes, and some of the findings from the registry are quite interesting, perhaps even counterintuitive. Looking at age groups, the 14-year revision rate is highest for patients aged 55-64 at 9.3%, followed by those aged 65-74 at 7.2%. Surprisingly, patients aged over 75 years old actually have the lowest 14-year revision rate recorded, at just 4.3%. The rate for the youngest group, under 55, was reported as 5.5% at 5 years, suggesting it might also be higher long-term.
That is surprising. You might intuitively expect older patients, maybe with poorer bone, to have more issues leading to revision. But the registry shows the opposite trend for overall revision risk. Perhaps lower activity levels or demands play a role.
That's a very common hypothesis that lower functional demands or activity levels in the oldest age group place less stress on the implant over time, leading to better longevity. There's also a very significant difference noted based on gender. The 14-year revision rate for males is reported as 9.5%, which is almost double the rate for females, which stands at 5.0%.
Wow, that's a substantial difference between genders needing revision surgery. What about differences related to how the implant itself is fixed or designed? Does cement matter?
The registry data shows some differences based on humeral fixation method. Uncemented humeral stems have a 14-year revision rate of 6.9%, based on a very large cohort of over 21,000 cases. Hybrid fixation, where the humeral stem is cemented but the glenoid base plate is usually uncemented, shows a lower 14-year revision rate of 4.9%, although this is based on a smaller cohort of around 2,600 cases.
So cementing the humeral stem seems potentially beneficial for long-term survivorship according to this large registry data. What about the length of the stem, short versus long?
That's another interesting comparison. Short humeral stems, defined as less than 100 millimeters in length, have a 14-year revision rate of 5.7%, based on about 10,000 cases. This compares favorably to conventional length stems, over 100 millimeters, which had a 14-year revision rate of 7.3%, based on over 13,500 cases.
So shorter stems potentially having a lower long-term revision risk according to the registry. This kind of granular real-world data is invaluable for surgeons and patients trying to understand long-term performance. Beyond needing a full revision, what are the most frequent or perhaps most problematic complications associated with RTSA?
Well, overall complication rates reported in various studies do vary, ranging from about 6.5% up to perhaps 15.2% in some series. It's worth noting, as mentioned in the sources, that complication rates tend to decrease as surgeons gain more experience with the procedure, indicating a definite learning curve. This is often cited as plateauing after performing somewhere between 18 to 45 cases. But yes, several specific complications are well recognized and important to discuss.
Scapular notching is one we've mentioned a few times now. Can you explain exactly what it is and how common is it really?
Scapular notching refers to bone erosion, or wear that occurs on the inferior aspect of the scapular neck, just below the implanted glenoid base plate. It's a common radiographic finding, meaning it's seen on X-rays. Historically, it was reported with very high incidence, sometimes quoted as 44% up to 96%, particularly with the original Gremon-style prosthesis design. This was strongly linked to that 155-degree neck shaft angle, which placed the humeral component very medially. The notching occurs because the medial rim of the humeral cup component impinges, essentially rubs against the bone of the inferior scapular neck during certain movements, particularly adduction, bringing the arm toward the body, and internal rotation.
So the implant is literally rubbing against the bone and wearing it away. What makes someone more likely to get notching? Can it be prevented?
Risk factors identified include placing the glenoid component too high on the glenoid face or tilting it superiorly, using an implant design with a highly medialized center of rotation, like the original Gremon, and possibly high patient BMI. Modern implant designs with features like lateralization of the base plate or glenosphere, or using eccentric glenospheres, along with surgical techniques focusing on achieving secure inferior placement of the base plate with perhaps slight inferior tilt, have all been aimed at reducing the incidence and severity of significant notching. Notching is typically graded on X-rays using classification systems like the Cerveau classification, which describes the extent of the bone defect ranging from grade 1, minimal, confined to the scapular pillar, up to grade 4, severe erosion extending under the base plate, potentially compromising fixation.
What about the joint actually dislocating after surgery? How often does that happen?
Dislocation, or instability, is another potential complication, reported in about 2% to 3.4% of cases in various series. It's considered a relatively common cause of early failure requiring intervention, usually occurring in the initial postoperative period before tissues have fully healed. The most common position or movement pattern that leads to dislocation is described as a combination of arm extension, internal rotation, and adduction, sort of reaching behind the back and across the body.
Are there specific factors that put a patient at higher risk for dislocation?
Yes, several risk factors have been identified. Perhaps the strongest is having an irreparable or failed subscapularis muscle. While RTSA is designed for a deficient rotator cuff overall, the complete absence or failure to heal of any repair of the subscapularis significantly increases the risk of anterior instability. Other risk factors include significant proximal humeral bone loss, making the humerus unstable, having the RTSA performed as a revision of a failed prior arthroplasty, dealing with a non-union of the proximal humerus, or having had a fixed irreducible shoulder dislocation preoperatively. Some sources also suggest a potentially higher rate of dislocation associated with the deltopectoral approach compared to the anterosuperior approach, although the reasons for this are debated and likely multifactorial.
Given how critical the glenoid fixation is, what about the base plate itself loosening over time? You mentioned that was a risk.
Yes, glenoid prosthetic loosening is unfortunately considered the most common long-term failure mechanism that necessitates revision surgery for RTSA. While the initial fixation achieved with modern techniques can be very strong, factors like micromotion at the bone-implant interface, inadequate initial bone quality, or progressive bone loss around the implant over time can eventually lead to loosening. It's noted that the incidence of glenoid loosening significantly increases after a revision. RTSA. One study cited reported rates around 25% at 5-year follow-up in that challenging revision setting. Treatment for established glenoid loosening is complex and often involves a staged surgical approach. First, removing the loosened components, thoroughly debriding the area, addressing any significant bone defects, often requiring bone grafting to fill the cavity, allowing time for healing, and then returning later to reimplant a new glenoid component, often using specialized techniques like bone grafting and locking screws for enhanced stability in the compromised bone.
That sounds like a very challenging problem to fix successfully. What about the risk of infection?
Deep infection is a serious, although fortunately less common, complication after RTSA. The reported incidence rates vary somewhat in the literature, with stat pearls mentioning a range of 1–10%, while the Bone School suggests 1–2% is more typical for primary RTSA. The risk is known to be higher in revision surgery scenarios, in patients with inflammatory conditions like rheumatoid arthritis, or when the surgery is performed for traumatic reasons like complex fractures. The large dead space created around the implant components can potentially be susceptible to bacterial colonization. Common organisms implicated include Cutibacterium acnes, formerly P. acnes, which is a skin commensal, as well as Staphylococcus species. Risk factors identified in registry data and studies include younger age, perhaps under 65, male gender, having the RTSA for a traumatic indication, and a history of previous failed shoulder arthroplasty. The gold standard for treating an established deep prosthetic joint infection is typically a two-stage revision procedure.
This involves removing all implants, performing extensive surgical debridement, administering prolonged targeted antibiotics, and then, only once the infection is confirmed to be eradicated, proceeding with reimplantation of new components. Specific antibiotics like vancomycin and clindamycin are often used as part of the treatment regimen, particularly for C. acnes infections.
Are there other bone-related complications besides the glenoid loosening? Can the bones fracture around the implant?
Yes, fractures around the prosthesis can occur, particularly fractures of the acromion or the scapular spine. The reported incidence is around 4% after RTSA. Identified risk factors include female gender, underlying osteoporosis, poor bone quality, having a preoperative anatomy with a very medialized center of rotation, and having rheumatoid arthritis. These fractures can sometimes heal with conservative treatment, like sling immobilization, but the union rates are often relatively low, perhaps only 40–50%. Therefore, operative fixation using plates, screws, or tension band wiring techniques is often recommended to improve the chances of union and restore the structural integrity needed for deltoid function. These fractures are sometimes classified using the Levy classification system based on their location and pattern.
And what about potential nerve injury during the surgery itself? Is the axillary nerve at risk?
Neuropraxia, which is a temporary nerve injury, typically due to stretching or bruising, of the axillary nerve, is a potential complication. The reported incidence is relatively low, around 0.5% to 1%. This is usually transient, meaning the nerve function typically recovers over time, although it can take weeks or months. It can result from traction on the nerve during positioning of the arm for exposure, particularly with hyperextension or abduction, or if there is significant lengthening of the humerus achieved during the procedure, which can stretch the nerve. Identified risk factors include the anterosuperior surgical approach, due to proximity to nerve branches, and any surgical technique that results in substantial lengthening of the humerus compared to the preoperative state. Permanent nerve injury is much rarer, but a devastating complication.
Finally, you mentioned base plate failure specifically as distinct from loosening.
Yes, base plate failure can occur, typically resulting from excessive micromotion at the bone implant interface, leading to fatigue fracture of the metal or failure of the fixation screws, or perhaps due to inadequate initial bone ingrowth in unsymmetric designs leading to instability. As we discussed earlier regarding fixation techniques, advancements in baseplate design, like porous coatings for bone ingrowth, and screw technology, variable angle locking screws, central compression screws, along with meticulous surgical technique ensuring flush seating and appropriate tilt, often inferior, are all aimed at reducing shearing forces and micromotion at that critical interface to prevent this failure mode. Studies, like one by Holcomb and colleagues back in 2009, have specifically investigated the causes and management strategies for revision surgery required due to baseplate failure.
It's certainly clear that while this procedure offers very significant benefits for complex shoulder problems, it also comes with a distinct and important set of potential complications that both patients and surgeons must carefully consider and navigate.
Absolutely. A thorough discussion covering these potential issues is a crucial part of the informed consent process. The sources also list other, less common complications that can occur, including things like an iatrogenic paraprosthetic fracture happening during the surgery itself, rare but serious vascular injury, the development of heterotopic ossification, which is abnormal bone growth in the soft tissues around the joint, and issues related to the surgical scar healing. And as mentioned, the learning curve for surgeons with this procedure is also recognized as a factor that can influence complication rates, particularly early in their experience.
With all this accumulated experience and data now on outcomes and complications, the field of reverse shoulder arthroplasty clearly isn't static. What research and advancements are happening now, and what's on the horizon looking ahead?
No, the field is continuously evolving, definitely, driven by that constant desire to improve patient outcomes further and reduce the rates of those complications we've just discussed. A key area of focus currently is generating robust, high-quality evidence, particularly for health technology assessments, HTA, of newer implant designs and surgical techniques. This is really important to ensure that new technologies are thoroughly evaluated for both safety and effectiveness before they become widely adopted in clinical practice.
So rigorous testing and evaluation of new developments is paramount.
Precisely. Research is ongoing in clinical effectiveness, often utilizing large patient cohorts and long-term follow-up data derived from sources like those national joint registries we talked about. These large-scale observational studies are vital for comparing RTSA to other treatments, such as anatomical TSA in specific populations like the older intact cuff group, and for detecting rarer but serious long-term outcomes like revisions or specific adverse events that might not be captured adequately in smaller clinical trials. They provide invaluable real-world evidence that complements the insights we get from randomized controlled trials, which often focus more on short to medium-term function and cost-effectiveness.
And technology is playing a big role too, isn't it? Both perhaps before and during the surgery.
Absolutely. Technological advancements are making a significant impact on both preoperative planning and the implants themselves. We're seeing increasing development and use of personalized, patient-specific implants, often created using 3D printing technology based on detailed analysis of the patient's preoperative CT scans. These are designed to be perfectly tailored to an individual's unique bone anatomy. The potential benefit here is to improve the fit and stability of the implant components, particularly the glenoid base plate in cases with significant bone loss, potentially reducing complications like loosening, instability, or impingement.
Patient-specific implants sound like they could really change the game in complex cases.
They are a very promising direction, yes. Alongside that, augmented reality, AR tools, are also being developed and explored as a way to enhance the precision of implant placement during the surgery itself. By providing real-time intraoperative visual guidance, potentially overlaying the surgical plan onto the surgeon's view, AR could potentially improve the accuracy of bony cuts and component positioning, which might lead to better functional outcomes and improved long-term implant survival. Still early days for widespread use, but developing fast.
And are there completely new types of implants being developed as well?
Yes, there's ongoing innovation in implant design. The stemless humeral component is one significant development that's gained traction. Sometimes called a canal-sparing design, this fixes the humeral component directly into the metaphysis, the upper part of the humerus, without needing a long stem going down the bone canal. The main theoretical advantage is preserving more of the patient's native bone stock in the humerus, which could be very beneficial if a revision surgery is ever needed in the future. It might also potentially reduce operative time and blood loss slightly compared to stem designs. Midterm results for stemless RTSA seem encouraging. Systematic reviews like the one by Castretzis have reported relatively low rates of humeral-related complications and revisions specifically for stemless designs. Studies by researchers like Teissier and Moroder are contributing to the growing body of evidence supporting their use in appropriate patients.
So, pulling all that together, what are the overall future directions for the field of reverse shoulder arthroplasty? Where is it heading?
I think the main focus is on continuous refinement of surgical techniques based on a better understanding of biomechanics and complication avoidance, and refinement of implant designs based on clinical evidence gathered from studies and registries. There's also a push towards establishing more international standards for assessing safety and efficacy of new technologies. Research is also delving deeper into understanding the wear properties of the different materials used in the implants, like polyethylene liners against metal or ceramic glenospheres, and the biological effects of any wear particles generated, as this ultimately impacts how long the implant will last. Additionally, there's ongoing work to better understand how specific patient demographic factors like age, gender, BMI, bone density really influence outcomes, so that treatments can be further optimized and tailored to individual patient risks and needs. The sources rightly emphasize that as the volume of RTSA procedures continues to increase globally, it's paramount for surgeons in the healthcare system to stay informed about the latest advancements, the supporting clinical evidence, and relevant regulatory processes. This growth must always align with principles of patient-centered care and sound ethical considerations.
What's really fascinating here is seeing that clear feedback loop, how the data gathered on complications and long-term outcomes directly drives the research and the technological development that's aimed at making the procedure even better and safer for patients in the future.
It's a truly dynamic field, yes, with a clear commitment from surgeons and industry to improving the lives of patients who often suffer from very debilitating shoulder problems.
Well, we've certainly taken a very deep dive into reverse shoulder arthroplasty today.
We have indeed. We've explored that core concept, reversing the normal anatomy to empower the deltoid muscle when the rotator cuff is irreparably damaged, a truly ingenious biomechanical solution when you think about it.
And we've mapped out the specific indications, things like cuff tear, arthropathy, and certain complex fractures, understanding why those conditions often require this unique approach, alongside discussing the crucial contraindications where it shouldn't be used.
We've walked through the meticulous preoperative planning process, emphasizing the increasingly important role of advanced imaging, like 3D CT scans, in understanding complex bone defects and guiding accurate implant placement. And we delved into the intricate steps of the surgery itself, highlighting the key decisions regarding approach, component positioning, and soft tissue balancing.
And we've outlined the phased rehabilitation protocol, stressing just how crucial that is for translating the surgical changes into real functional improvement and guiding patients safely through their recovery journey.
And finally, we've examined the real-world outcomes, noting the generally excellent pain relief and functional gains achieved for activities of daily living, while also squarely facing the potential complications like scapular notching, instability, infection, and component loosening. We saw some surprising insights from registry data too, particularly around how factors like age and gender can influence long-term revision rates.
It's clear that reverse shoulder arthroplasty, while undoubtedly complex and carrying specific risks, offers significant hope for substantial pain relief and improved function in many challenging shoulder cases where traditional options might fall short.
It truly represents a powerful solution for a specific, carefully selected group of patients who, in the past, might have had very limited options for meaningful improvement.
If you found this deep dive valuable, please do consider rating and sharing it so others who might benefit can discover it too.
Indeed.
This whole discussion does raise an important question for the future, doesn't it? As technology continues to advance, allowing for increasing personalization with things like 3D printed patient-specific implants and augmented reality guidance systems, how will the orthopedic field effectively balance these highly tailored, potentially complex solutions with the ongoing need for standardized, evidence-based practices to ensure the best, most reliable, and safest possible outcomes for every patient undergoing this life-changing procedure?
That's a fascinating challenge and a key consideration as the field continues to push boundaries. Thank you for joining us for this exploration.